Our next patient is a 75-year-old female smoker who presents with a 6-hour history of severe abdominal pain. Her biochemical results show an elevated lactate and acidosis, while on physical examination, the abdomen is soft. Now we know that severe abdominal pain in an elderly patient, especially with these biochemical findings, should immediately raise concern for a possible vascular or ischemic cause, particularly mesenteric ischemia. Starting with the plain radiograph, the most noticeable feature is a dilated loop of small bowel in the mid-abdomen. Interestingly, there's no gas seen in the large bowel, although the cecum does contain feces. There's also no free intraperitoneal gas, which is reassuring as it indicates that we are not dealing with perforation at this point. The CT scan, however, gives us more clarity. We can see a large volume of free fluid, or ascites, surrounding the liver and spleen, and also pooling within the pelvis. What's more concerning is the oedematous loop of small bowel in the left iliac fossa and pelvis. This loop is significantly thickened and isn't enhancing well compared to the rest of the bowel, a clear indicator of bowel ischemia. Furthermore, on the coronal images, the marginal arteries aren't filling with contrast, reinforcing the suspicion of vascular compromise. Given this combination of findings, the dilated small bowel loop, the lack of enhancement, and the free fluid, it becomes quite clear that we are dealing with acute small bowel ischemia. The absence of free gas, which is a late feature, tells us that the bowel hasn't yet perforated, but this patient is at significant risk. At this point, the diagnosis is small bowel ischemia. The patient needs urgent surgical intervention, including resection of the ischemic bowel segment. Time is critical here, because delayed intervention increases the risk of necrosis and perforation, leading to much higher morbidity and mortality. Now let me touch on the differential diagnosis for small bowel ischemia. We often consider other causes, such as lymphoma, a history of radiotherapy, Crohn's disease, or even amyloidosis. However, in this case, the acute presentation, history of smoking, and absence of pre-existing bowel disease make thromboembolism the most likely cause. Speaking of small bowel ischemia, it's important to note that the diagnosis is often challenging in the early stages. Bowel obstruction can be a common presentation in both the emergency and surgical departments. The symptoms can be quite nonspecific. Severe pain in the presence of a soft abdomen, as we saw with our patient, is a clue. Over time, as the ischemia progresses, we would expect to see dilation of the bowel, and perforation can occur, which is a late and dangerous finding. CT with post-IV contrast is crucial in identifying small bowel ischemia. The sensitivity is reported to be between 76% and 100%, and increases when we see 2 or more signs. Key imaging features include bowel wall thickening, mesenteric venous engorgement or thrombus, and reduced bowel wall enhancement. Intramural pneumatosis is another key finding, but we didn't observe that in this patient. Portal venous gas is also a late sign, but wasn't present in our case. So to summarize, this is a case of small bowel ischemia secondary to thromboembolism. The patient needs urgent surgery to remove the ischemic segment and prevent further complications. Early diagnosis and management are the key to preventing bowel necrosis and improving outcomes. That wraps up the discussion for this case. Let's move on to the next one.